He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome back, folks. It's the Stay Off My Operating Table podcast with Dr. Philip Ovadia. We're glad to have you. We've got somebody here who I'm excited to hear from, not because I personally have experienced this, but because I've been through it with a woman who has personally experienced this. Dr. Amie Hornaman. Dr. Amie, welcome.
Thank you. Thank you so much for having me. And I look forward to unpacking what you went through with a woman.
Oh, no, we don't have to talk about me. But you are the author of The Thyroid Fix, the no-nonsense guide to fix fatigue, fogginess, and fat that won't budge. Every woman over 35 needs this.
Everyone.
Phil, do you know any women over 35?
I do. And I'm also going to tell the men in our audience to pay attention as well, because this isn't a woman-only problem. And thyroid disease is really one of those sneaky things that's, I think, been underappreciated by the traditional medical system. And as we'll talk about, it's a situation where we don't do the right testing and don't really understand what it's about. I've followed Dr. Amie's work for quite a while now. Finally got to meet her for the first time in person a few months ago at Hack Your Health conference, and was really excited to get her on the show so we can have this conversation. So maybe start, Amie, if you don't mind, with your personal story. What got you interested in this and how you got to be the thyroid fixer?
Absolutely. Like many of us in this space, this health and wellness space, it's a pain to purpose story. So this goes back many years ago, 25 years ago, into my 20s. I used to compete. I did fitness and figure competitions in that bodybuilding realm. So for your listeners, basically think about getting on stage in a bikini after dieting really hard for about 12 to 16 weeks. So I had done plenty of these shows before. I had prepped my body in a certain way to get lean, to get muscular, and basically to step on stage in a bikini. This one particular show I'm getting ready for, I use a coach, the whole deal, because you need a coach to guide you. I'm checking in with him every single week, stepping on the scale, sending before and after pictures, and I'm getting ready for this show. And instead of the scale going down, it's going up. Every single week I get on it and I see an additional 2 to 5 pounds. Now, that really started messing with my head, of course. I'm a woman and I'm busting my butt getting ready for this competition where I should be getting leaner. I should be losing fat. I should be feeling great. And it's going in the opposite direction. Now, this is over the course, I'm shortening the story, of course, but over the course of many weeks, that scale actually went up 25 pounds in 4 to 6 weeks, very rapidly. And I'm sorry, I don't care what camp you're in, calories in, calories out, calories don't matter, whatever. That biologically doesn't make sense. When you are eating chicken, broccoli, and asparagus, and you're literally going to the gym twice a day, your body should not be accumulating excess fat. It just shouldn't be. So I really felt like my body was rebelling against me at that point in time. I did what we all do. I went to my doctor and I said, yeah, hey, doc, here's what's happening with my body. I'm wearing big sweatshirts at the gym. I'm frustrated. I'm crying. I'm beating myself up. I'm not eating bonbons and sitting on the couch. This is what I am eating. And I handed him my diet. And he did a couple tests, which I don't know what he did back then. I have a guess. It probably was just TSH, right? Checking my thyroid, just TSH. And he said, you're normal. Everything is fine. These labs look great. You're normal. I didn't feel normal, didn't feel great. So I went on to doctor number 2, and then 3, and then 4, 5, 6. And all of them gave me the typical medical gaslighting that women still hear today. You're normal. Everything is fine. Just eat less and exercise more. It's all in your head. Yeah. So I went to doctor number 7 reluctantly. And to this day, I look back, I go, wow, I kept going. Thank goodness I kept going. I could have easily stopped at doctor number 4 because that's 4 white coats telling me, no offense to any of us here, 4 white coats telling me that I'm fine, that it must be me. It must be my fault. Maybe I need to work out 3 times a day. Maybe I need to restrict my calories more, right? 7th doctor touches my throat and says, swallow. She goes, oh, yep, I feel a nodule. Per your labs, looks like you have Hashimoto's. Okay, I'm going to give you a pill. She gave me Synthroid, which is T4, which we can unpack a little bit more. She gave me Synthroid. I left her office pumped up. I'm like, yes, I have a pill for this. It's going to fix me. This is it. I have an answer. I have a name for what is going on with my body. I gave that 5 months. I did not lose 1 pound. But at least I knew what was going on. So I start researching more. I get back on my big gateway computer at the time and I start Dr. Googling, right? And I keep hearing the name. This is where the universe is speaking to you. I kept hearing the name of this functional practitioner. And I heard it multiple times. I'm like, okay, I get the message. Thank you. Went to see him. Back then, we didn't even use the term functional. It was integrative. It was alternative. It was a little bit on the fringe, like a little more woo, really looked down upon in the medical community, a little bit woo. But he sat with me for 90 minutes. He did all the testing I needed to do. He explained to me what my body was doing, how I don't properly convert T4 to T3, how T3 is the active thyroid hormone. This is amazing. And he changed my life and then changed my career path. So he became my mentor. I totally shifted careers and went down this path of being a thyroid and hormone expert because I was in a major medical system. I was in UPMC Pittsburgh. That's equivalent to Mayo Clinic. That's equivalent to Cleveland Clinic. Top of the line docs there. And still, 6 of them misdiagnosed me. The 7th one didn't know how to treat me.
Yeah, and unfortunately, it's a story I hear a lot. And even as a heart surgeon, right, who now doing what I do, right, I have women and men, but mostly women coming to me all the time. And they have gone through a similar story. And maybe they figured out it was something to do with their thyroid, but then it didn't really get addressed correctly, treated correctly. It got misdiagnosed. And it's just one of these areas of medicine, right, that quite frankly, I never used to really think about. I'm a heart surgeon. The thyroid is maybe a little bit in my way when I'm doing certain things up in the neck and trying to get to the blood vessels, and didn't think all that much about it, but obviously it's so vital. So let's unpack a little bit just how vital the thyroid is. What does it do? What does it do? And then you mentioned T4, T3. Maybe let's give a little bit of the basic background for our audience to understand what we're talking about there.
Absolutely. So starting with the thyroid gland, it is the master gland. And this is my whole argument as to why we have to focus on it more. And especially in the area of women's health right now, of course, we have a lot of focus on perimenopause and menopause, hormones. The black box warning got taken off of our bioidentical hormone replacement. That's fantastic. But what controls those hormones? What controls our entire body? I always say from head to toe, it runs the show. That's the thyroid. So the thyroid is the master gland, literally controlling the hair growth on your head, of course, your metabolism, dictating whether or not you're going to gain weight or whether you even have the ability to lose weight if you're trying to. It dictates your energy, your cell turnover, your body temperature, and in your line of work, it dictates your heart rate. And we see a large amount of heart palpitations when someone is under-medicated or over-medicated. We'll see heart issues in a non-diagnosed, like I was, undiagnosed, misdiagnosed, or mistreated situation of hypothyroidism. We'll see a lot of AFib or just blips in general. Or what I see is very low heart rate, to where someone, when we start treating them and we bring them up into a resting heart rate of 65, they go, oh my gosh, I feel like my heart's racing. It's coming out of my chest. I go, okay, what are you? They're like, it's like 65. I'm like, that's because your heart rate was like 40 before, not because you were Lance Armstrong, but because you were hypo, low, and slow. You weren't a world-class athlete. You were just so hypo that your heart was beating more slowly. Your whole system is slower. Your gut motility, i.e. constipation, is slower. We really have to look at the thyroid when we look at any system of the body to make sure that it is not just normal, but optimal, to make sure that it's optimal. So then we go into the thyroid hormones. So your thyroid gland produces actually 4 thyroid hormones: T1, T2, T3, T4. T1 we can set aside. It's not important. When we look at what we can test on a lab, we're looking at T4 and T3, specifically the free version. So we say free T4 and free T3, 2 tests that are very important in the full thyroid panel to get, because we're looking for the unbound thyroid hormone that's ready to attach to your cell. Now let's go one step further. We actually only have receptor sites on our cells for T3. That is the active thyroid hormone. T4 is completely inactive. It has to go through a transformation. We call it conversion. It has to convert and become T3 in order for it to do anything in your body. So going back to my story, that doctor gave me a pill, Synthroid, levothyroxine, that was T4. That had to convert and become T3 for it to do anything in my body, to even give me a fighting chance at losing the weight that I put on. I don't convert very well. That process of T4 to T3 conversion, I always joke and I say, it's like running 10 Tough Mudders in a row. It's really hard for your body to do. Things like stress and insulin resistance and iodine deficiency, magnesium deficiency, selenium deficiency, estrogen dominance, all of these things can get in the way of that T4 to T3 conversion, to where some people just don't convert that well. And in reality, in my practice, we see the stat of 100% of our patients need some form of T3 in the mix, if not T3 only. Whereas a stat that I heard at A4M was 98% of us need T4 and T3. Only 2% of those with hypothyroidism can take a T4 only pill, a T4 only treatment, and do well on. Over here in my practice, I say it's 100%. I never see a patient do well on T4 only. I really don't, because it is inactive and has to convert.
Yeah, I was just going to ask, do you know, my guess is this number is really high, right? But if you look at the percentage of patients that are on thyroid medicine in this country, how many of them are on T4 only?
Most, because it's standard of care. It's standard of care. So as in medical school, when they go over the thyroid, it's test TSH. If TSH is above a 4.5, give T4 monotherapy, because you know it'll work. T4 monotherapy works all the time. That's what they tell you. And so you give someone that T4 pill, pat them on the back, send them out the door, let them know you'll test them in 6 months. Thank you very much, Sally. We'll see you later. The problem is that's a very limited training, and it's a very narrow mindset when it comes to what the thyroid does, how it works in our body, and all of the different treatment options we have out there. When I'm asked, what's your favorite thyroid hormone replacement, I call thyroid medication thyroid hormone replacement, so people don't freak out over the medication word. What is your favorite thyroid hormone replacement? I say the one that works for you, in the combination that works for you, and in the dose that works for you, because we have options. We have options. And I'll leave you with a quick story before we move on. I was speaking to a group of integrative wellness practitioners, and I was talking to them about the tests that we need to do. We need to do the free T3. We need to do free T4. We need to do reverse T3, because that shows us how well you are converting. We need to test the antibodies. And then over here, we need to get out of the Synthroid box. I said, we're in this Synthroid box. This is standard of care. This is what we do for everyone. It's leaving people sick. And I said, why is that? And the one doc raises his hand and goes, that's all we've learned. And that's proof positive. That's all they're learning in medical school. And we need to branch out if we're truly going to help people.
Remember, non-medical expert here. What's TSH?
Oh, good question. Thyroid stimulating hormone. So TSH is basically a brain hormone. So we have the hypothalamus in our brain talking to our pituitary, talks to our thyroid. And the pituitary releases thyroid stimulating hormone. So exactly that. It's like poking the thyroid. Come on, you got to wake up and do your job. Let's go. It's a brain hormone, though. So when you think about it that way, you go, yeah, if we're testing the health of the thyroid, shouldn't we be testing the thyroid hormones?
That was
And
my question.
right?
Why are they
Yeah.
testing TSH?
Exactly. Exactly. And that's the
The
down.
answer is there's no good answer.
That's all they've learned. That's the why. Is
Because
Exactly.
yeah, that's how it's always been done. It's interesting because I have thought about this right now, knowing what I know, like, why did we start with TSH? And as best as I can determine, that was the first thyroid related hormone, we'll call it, that we discovered and were able to test it in the lab. And so then when we then got T3 and T4, right, and everyone basically said, you don't really need to worry about that because TSH is what controls the thyroid. So if we just look at the control of the thyroid, you can then assume what the thyroid is actually doing. But of course, we know that's not a very good assumption. But yeah, it's just one of those, it's just another example in medicine, right? Where we, for whatever reason, historically started down one pathway and no one could really think to change the course. And it just, yeah, it's a very fascinating example of how we get trapped in a certain way of thinking within medicine, and we can't really see outside the box, despite the fact that it's the evidence that is not working should be obvious to just about every doctor, right? Because the Synthroid-based, TSH-based way of managing thyroid disease, most people don't get good results from it. And they keep going back to their doctor, and the doctor keeps adjusting the dosage and never really thinks that maybe there's something that we're missing here.
Yes, 100%. I love it. I love that you're touching on this. And let me add too that the TSH range has actually been changed throughout the years. So the American Thyroid Association, they actually argued for this. It used to go up to a 10, maybe higher before, but I remember a 10. And then they argued it down to a 6 as a cutoff. So real quick for your listeners, TSH is one of the only lab markers where high means low. It's important to say that. So the higher the number of your TSH number, the lower and slower your thyroid is functioning. Because essentially, it's like screaming at your kid. So you might walk in a room and you go, Johnny, will you pick up your toys? Okay, that's like a level 2. And then Johnny's not listening. And it's, Johnny, will you pick up your toys, please? Now we're getting to level 5, and then we go to a level 10. Same thing. It's your brain screaming at your thyroid that, hey, thyroid, you're not doing your job. So as TSH goes up, that's indicating that your thyroid is very low and slow functioning. Now, that lab value range used to be a 10, then it went to a 6. Now it's a 4.5 in conventional medicine. But in functional medicine, we say we would really like that TSH to be below a 2. We have found that when we put a bullseye on those lab markers and we call that optimal, that this is where someone is going to feel their best. Now, just having a TSH below a 2 does not negate hypothyroidism. We can still see a subclinical hypothyroid state with low free T3 present, even with a TSH of a 1.5. We can still see someone having Hashimoto antibodies, even with a TSH of a 1.5. We can still see someone in lockdown survival mode, which is actually termed human dormancy syndrome, when the reverse T3 is elevated, which indicates that you're not converting T4 to T3 very well. So there's so much more than just the TSH.
Okay, you're talking about stuff that doctors would be looking for and or be able to interpret in a lab. But let's talk about the folks who are the sufferers. What are the symptoms? What are we looking for that would indicate you've got a malfunctioning thyroid problem?
Yes.
I'm guessing, even as I asked the question, that if it's the master hormone, it could be all over the map, but maybe give me the top 5 greatest hits or something like that.
Oh, yeah, no, I break them down. So even in the book, I break them down. There is the top 3. And now these are the ones that I see all the time. They are the biggest complaints of my patients, my followers, my listeners. Number 1, weight gain or inability to lose weight. Your metabolism totally shuts down. It doesn't matter if you are eating perfectly, I don't care whether you're doing keto, you're doing carnivore, you're counting your calories, you're counting your macros, you're eating all organic, you're going to the gym, like I was going to the gym once, twice a day. Nothing will work if your thyroid is low and slow. I had a patient that she came into the practice. She was on T4 only, of course, so her thyroid was still not optimized. We did not have an optimal thyroid situation going on. She was about 150 pounds overweight. She was type 2 diabetic, and she was even on a prescribed GLP-1, which we know there's the big fad with the GLPs right now for weight loss. She was even on that, and her body would not release the weight. She could not lose the weight. It wasn't even pushing down her A1C. So we actually optimized her thyroid, got her treatment the right way, added in some T3, brought her reverse T3 down, the whole thing. She finally lost the weight. So that is how important the thyroid is. If you're on a GLP-1 and it's not working, you better look at your thyroid because it is controlling your metabolism. Number 2 would be hair loss. I have women that literally show me pictures of the hairballs that come out of there. They're gathering them because they want somebody to believe them. They're like, no, really, this is just today. This is what I lost just today in the shower. They have shower PTSD. They won't wash their hair for 5 to 7 days because they don't want that shock of what comes out, right? Hair loss is a big one, hair thinning, hair breaking, and then energy. So the hypothyroid fatigue is like a crushing exhaustion. It's that one where your eyes are nodding and you're like, I don't know how I'm going to make it past like noon today. This is really bad. It's where you stare at the couch at 2 p.m. going, please, can I just lay down for 20 minutes? That's all I need. I just need 20 minutes. It's a bone crushing fatigue. Those are the top 3. Now, below that, we have some pretty normal symptoms like cold intolerance, cold hands, outer corners of your eyebrows thinning, constipation, joint pain, brain fog, anxiety, depression. And then we'll have some wacky symptoms that you don't hear that and go, oh, that's tied to thyroid. But like I mentioned earlier, heart palpitations, different heart issues, elevated cholesterol panels, elevated blood pressure, frozen shoulder, migraines. Those are all could be connected to your low thyroid. We don't know, but they could. So let's just treat properly, get you into an optimized state, and then we're going to see if those wacky symptoms go away.
Okay, I have a 2-part question. The first part of the question is, your practice, from what I can tell on your website, is largely targeted at women in their 30s, 40s, 50s. I'm assuming that's because that's when this normally starts happening.
Exactly.
I would like to know the why for
Sorry.
that.
Okay.
But I'd also like you, if you can, why the heck did it happen to you in your 20s?
Yes. Okay. That all ties together. The triggers of hypothyroidism. So at the Advanced Thyroid Hormone Clinic, we do thyroid and hormones together. So what we see, whether it's a woman in her 30s or really a woman in her 60s, you have to address that low thyroid function, but you also have to look at and address hormones because the thyroid's the master gland. It controls hormones. So we'll see women have extremely low progesterone in their 20s, maybe an onset of polycystic ovarian syndrome. We know that the thyroid controls fertility. Large amounts of miscarriages occur when the thyroid isn't optimized, in addition to just not being able to get pregnant in and of itself. So the thyroid has an impact on hormones. But then there's also the inverse relationship of what are the big triggers of hypothyroidism. Before we get into that, we have to give a stat that 95% of all hypothyroidism, hypo, low and slow thyroid function, is Hashimoto's. So that's an autoimmune disease. And we are seeing a rise of autoimmune diseases.
95%
overall,
of
95%.
hypothyroidism is Hashimoto's.
Is Hashimoto's. Only 5% occurs from things like birth control used for more than 10 years increases your risk of hypothyroidism by 243%. Some beta blockers do kind of tank the thyroid, going through chemotherapy, radiation, eating disorders, extreme dieting, extreme exercise. That can tank your thyroid, but that can also be a stressor that turns on Hashimoto's. So it's an either or when you start getting into the restriction and over-exercising mode. We see a lot of CrossFitters come up with thyroid conditions just because it's such an intense stressor on the body. And back when CrossFit was really big, people would do it 7 days a week and crush their adrenals. That would trigger Hashimoto. So when we're looking at Hashimoto's, we see 3 stages in a woman's life where it tends to rear its ugly head. And that is pregnancy, perimenopause, menopause. So this comes into what I call thyropause, which is basically when your thyroid gland craps the bed after the age of 40 due to those fluctuating hormones. So first, let's take pregnancy, because you go, wait a minute, the pregnancy occurs 20s, 30s, maybe 40s. Yes, so pregnancy is a beautiful thing. Bodies are made to do it. Huge stressor on the body, crazy hormonal fluctuations. So that stressor combined with erratic hormones can turn on Hashimoto's. Many women will say they have postpartum thyroiditis. That's just a pretty name for Hashimoto's that turned on during pregnancy. And then we move into perimenopause and menopause, where we know hormones are on a roller coaster ride and eventually they're going into the toilet. So in that time of a woman's life, that is when thyropause or thyroid conditions will also appear because of those fluctuating hormones. For me, I think it was a combination. I think because I was diagnosed with Hashimoto's, I did have positive antibodies. I think the stressor of the extreme dieting and exercise that I had done multiple times just put enough stress on my body that it just tipped the scale, no pun intended, and Hashimoto's appeared.
Now, so I need to jump in. So I graduated medical school in 1998, 27 years ago. And I remember Hashimoto's as one of those things, you learn what it is, and maybe you'll see a case of this in your career. It's rare. And here we are 30 years later saying it is ubiquitous, essentially. And I guess my question there is, how much of that do you think is just misdiagnosis, right? We had no idea how to really look for it, versus are there some things in our environment that are causing this to become a lot more common?
I think a little bit of both. I think both. I think on the one hand, to answer the first point that you made, when we look at the assays, when we look at the testing ranges, so on LabCorp for thyroid peroxidase, which is one marker of a thyroid antibody, we look at thyroid peroxidase and we look at thyroglobulin antibodies. When we look at that TPO, we see the reference range as less than 34. Okay, so I like to think of autoimmunity, any autoimmunity, as you have these soldiers that are confused in your body and they are attacking XYZ. So in the case of rheumatoid arthritis, it's joints. In the case of Hashimoto's, it's your thyroid. So you have these soldiers that they think that your thyroid is a bad guy and they like to go out and beat it up. So over time, as we see someone move through the stages of Hashimoto's, if we do an ultrasound of their thyroid, it's going to look like Pac-Man started eating the sides of it. It's really jagged, it's smaller. And when a gland gets beaten up every day, do you think it's going to perform well? No, it's really not. So on the one hand, we have those soldiers going out and we need to calm them down and unconfuse them in a perfect world. But they're going out and they're beating up the thyroid gland. Now on that test, so LabCorp standard reference range says you need to have 35 soldiers for us to say, yes, you now have Hashimoto's. You are officially diagnosed. What if we have 30? I still got 30 soldiers going out and beating up my thyroid every day. I'm still suffering with symptoms, but you're not actually going to give me that pretty diagnosis until I hit 36 soldiers, which could be 10 pounds from now, after I lose my job and all of my relationships. So I want to look at any antibody as an indication that you are maybe in the beginning stages, but you are in this state of Hashimoto's. And if it pairs up with your symptoms, if you're also telling me, yeah, I'm gaining weight, I can't lose weight no matter what I do, I'm tired, my hair's falling out, I'm constipated, I got brain fog, I got anxiety, I can't sleep. Well, that's enough for me to say there's something going on. Let's look a little bit deeper. There's something going on here. So I think it's a combination. And then to your point, yeah, we're living in a very toxic world. It's exponential. All the time it's something else, whether it's BPA or glyphosate or stuff in shots that we're taking. There's all kinds of assaults on our body day after day, month after month, year after year that is absolutely increasing autoimmunity across the board, not just Hashimoto's.
Yeah. And in fact, once someone has one autoimmune diagnosis, they're much more likely to get additional autoimmune diagnoses. So Hashimoto's is something that ends up being common. Sometimes it's not their first autoimmune diagnosis. They've been diagnosed with the arthritis or the irritable bowel disease, inflammatory bowel disease or something, and then Hashimoto's comes on. And I think the other point that's important, going back to what we were discussing before, right? Most doctors stop at testing TSH. And if they're not going to test T3 and T4 levels, they're certainly not going to go testing thyroid antibody levels. It is probably very underappreciated because of the lack of testing around it. So you mentioned T4, you mentioned T3, and you gave a brief allusion to T2 and T1, which doesn't seem to be of much importance, but T2 is something that, quite frankly, I hadn't heard about. I think before I heard about it from you. As you go through everything around the thyroid and you learn all the biochemistry in school, T2 never gets mentioned. What should people know about T2?
Oh, I love T2. I have a whole chapter in the book on it. It is the forgotten thyroid hormone. So when we look at T4 and T3, we really focus on those two because we have assays, we have tests for them, and we have pharmaceuticals for them. So we can actually replace the T4 and or the T3 thyroid hormone that your body is no longer making in proper amounts anymore, not making well anymore. We can replace that. T2, we don't have a test, a universal test outside of studies, of research studies. We don't have a test for it. And kind of thankfully for right now, there's not a pharmaceutical for it. It is available in supplemental form, and that's good because of what we're going to talk about. T2 is very metabolically active, but it does not have, it has no thyromimetic effects, meaning it's not going to change your labs to where your doctor will look and say, oh my gosh, you're hyperthyroid. It's not going to push down your TSH, and it's not going to affect your cardiovascular system. So we're not going to get that racing heart, the elevated blood pressure, the elevated heart rate like we do with T3. Now, I'm not saying that to poo T3. I love T3. We already said it. 98% in my practice, 100% of our patients are on some form of T3 in some dosing regimen that works for them. But T2, what it does is it works at the cell level. It works at the mitochondrial level. And it increases our basal metabolic rate. So literally the amount of fat that we're burning at rest. Now, T3 will also burn fat, but T3 will burn fat and muscle. It's like what we're seeing with the GLPs, right? That people are getting Ozempic face and they're losing their butts and they're losing their muscle and they look like Skeletor. It's not good. We want to keep our precious muscle, especially if you're working really hard to build it and you're eating the protein and you're working out and all that. You want to keep that. And as we age, it becomes even more important. We want to avoid something called sarcopenia, which is a loss of our muscle tissue that does happen as we age, because then you're at an increased risk of falls and breaks and all of that. So we want to keep our muscle. T2 only burns body fat. It leaves muscle alone. And in my past world, the bodybuilding world, I always joke and I say, bodybuilders were actually the OGs of biohacking, by the way. Like long before Asprey came along, we were experimenting with everything, including peptides, way back when. So the one thing about bodybuilders is they'll try stuff, anything pretty much, to lose body fat to get on that stage. And truth be told, many of them will use not prescription for them, T3, they'll get off the black market, right? And they'll use it to lose weight. But the problem is that they will lose muscle too. And that's the last thing that you want to lose as a bodybuilder. So I'm watching this interview and I've been studying T2 now for 20 years. And I was watching this interview with one of the top trainers to these athletes, to the top level professional bodybuilders, fitness and figure athletes. And he says, for my ladies especially, I don't let them use T3 because I use T2 because it's only going to burn their body fat and it's going to leave their muscle alone. And they're not going to come out the other side of this show with a thyroid problem. And that's the non-thyromimetic effect. It doesn't affect the labs. It doesn't have that negative feedback loop back to your hypothalamus, your pituitary, and your thyroid that basically shuts down your own hormonal production of thyroid hormone when you take it. So for me, I truly believe that it is one of the answers to the obesity crisis that we have. I know the GLPs have come along. I get it. They've been an answer for so many, but let's face it, they are causing issues. We are seeing gastrointestinal issues. We are seeing the loss of facial fat, the loss of muscle, and sometimes it's cost prohibitive. So with T2 coming in to literally increase our metabolism, increase our thermogenesis, increase the amount of stored body fat that we have, decrease inflammation, decrease oxidative stress, that's just a win-win all the way around. So for me, I love T2, especially for anyone that needs to lose weight.
Yeah, what might be, so I guess weight loss is a big one, but are there other indicators of if people are on let's say they're on a good kind of thyroid regimen and it's still not quite getting the results, when should we think about bringing T2 in? Or should T2 really be at the beginning of this process for most people?
The nice thing about T2 is that anyone can use it. So you actually don't have to have a diagnosed thyroid condition to add in T2. Because it is working at the cell level, the mitochondrial level, because it does not have that feedback loop or the thyromimetic effect, we can use T2 in anyone that has low energy, anyone that needs to lose excess body fat. If you're saying, hey, I think my metabolism is low, that's where you would add in T2 to increase your metabolism. Now, it also works. Multiple studies have been done on this, and I've been, like I said, really diving into the studies for the last 20 years. There are multiple studies showing that improvements in fatty liver disease, improvements in lipid panels. We're seeing, like I mentioned earlier, a reduction of inflammation and in oxidative stress. T2 also helps with the conversion of T4 to T3. So what I say to listeners out there, listen, if you are stuck on T4 only, if you're in that Synthroid box that we talked about, and your chances of T4 getting you optimized and you living your best life on it, and you feeling your best, pretty slim to none, add in T2. Because at least with T2, you're going to help your body convert that T4 over into the active form T3. You're also going to improve your metabolism, lower inflammation, lower stress. So it's improving the situation across the board, especially for those who are stuck on T4 only. But it's important to note that it can be used by anybody.
I know this isn't accurate, but this sounds like a woman problem.
1 in 8, Jack. 1 in 8. So yeah, we get hit harder. So what you guys have that we don't is you have extra testosterone. So even if you're a man, and really my second favorite hormone next to thyroid hormone is testosterone. So even if you're a man with low T, right? Let's say your testosterone is, I'm so sorry, maybe a 300. At a 300 total testosterone, you're still going to have more than we do. Our average, our optimal is around a 50. Average is anywhere between 20 and 80 is where most women will float. That testosterone is a very protective layer against autoimmunity. So you guys get less autoimmune conditions despite the toxic environment that we're in, despite any stress that you might go through that turns on that autoimmune switch. You have that shield of armor, i.e. testosterone, to protect you. Because we have less testosterone, our protection is lower, and we have the rapid fluctuating hormones. We go through a 28-day cycle. You guys have the same hormones every day. So the rapid cycling of our hormones, even outside of the pregnancy, perimenopause, menopause that we talked about, just being a woman and having a 28-day cycle sets us up for a greater risk of autoimmunity. So hypothyroidism, The stat is 1 in 8. That's just, remember, that's just the diagnosed.
Yeah, it's a diagnosis.
That's the diagnosed. So I'm taking it to 1 in 3, 1 in 4.
I had an old girlfriend who was diagnosed with Hashimoto's, and without going into all the details, again, I'm looking at your website and what's this all about? And you mentioned iodine, and we took a vacation to the ocean. We live in the desert, and we took a vacation to the ocean, and the 3 or 4 days we were at the ocean, it was like her symptoms went away. And the story was that there's more iodine in the salt air, and that's what helped her. I don't know. But that mention of iodine and Hashimoto's rang this bell.
Yeah.
Help.
Yeah. Yeah, absolutely. So it's a hot button topic, whether you
Oh
know
my-
it or not. It's a hot button.
I don't know. I'm just,
Yeah, no, it is. If you look at we'll say the functional wellness, health and wellness community that we're all in, you would probably get about a 60-40 split, would be my guess. 60% of us say iodine is great. I'm going to go into the science as to why. 40% tell you to avoid iodine. And with those 40%, I really scratch my head because, again, I come back over here to science. Science. What do we know? Okay, we know that the thyroid gland needs iodine to produce thyroid hormone. We know that iodine is required for that T4 to T3 conversion process to occur. One of the biggest contributors to an elevated reverse T3, remember we said earlier that puts you in human dormancy, it puts you in hibernation mode, survival mode. One of the biggest causes of elevated reverse T3 is low iodine. Iodine is antibacterial, antifungal, antiviral. Our breasts actually need around 6 milligrams of iodine a day. Thyroid glands around 5 to 6. It is protective against cancer. It turns on the p53 gene that suppresses tumor cell growth. It is so when we look at the periodic table, we see halides and halogens. So whether it's a bromide or a bromine, chloride, chlorine, fluoride, fluorine, it competes at the cell receptor site with iodine. Iodine is the only element that can come in and bounce off those toxic halides from your cells. So fluoride, let's take fluoride, for example, very toxic to the thyroid, huge contributor to hypothyroidism, in addition to lowering IQs in boys and interfering with reproduction, all of that. So number one, get a fluoride-free toothpaste. But number two, we've all been to the dentist. We all took those little pink pills when we were little, the fluoride treatments at the dentist, right? So we've all been exposed in addition to fluorides in your water. What are you going to do to protect yourself and your kids from the fluoride exposure? Yeah, you can get the fluoride-free toothpaste, but you're still getting exposure. You have to take iodine in order to give the body what it actually needs at the cell receptor site and detox yourself from the exposure to the toxic halides. Chlorine in our water, everywhere. Bromide in your clothes, on your carpets, in your furniture. God forbid you live by a golf course. It's in your food. We're exposed to these toxic halides every day. So when we just look at that science that I laid out, how can we say to avoid iodine? And then anecdotally, Jack, your girlfriend experienced it and you saw an improvement. I hear that from patients all the time. Even when we start.
so she wasn't crazy. She
No.
might still have been crazy, but
Yeah, she still could have been crazy, but she wasn't crazy at that moment in time when she felt better.
I'll be darned. That is just astonishing. Okay, so I'd like to summarize what I think I've heard. Women suffer from this more than men simply because we've got buttloads more of testosterone, even if we are wildly low in testosterone as males. In addition, women have naturally fluctuating hormones, which adds stress. All of these things combined, plus our toxic environment, stress the thyroid, which is the master. Remember, I'm not medical.
That's right.
And women, probably far more women than are diagnosed, are suffering from some sort of dysfunctional thyroid. am I right so far?
You
Have I
you
got it?
nailed it.
Okay,
Absolutely.
so let's take it to the next step. I think of there being two levels of treatment. There's what do you do to take care of yourself, and when that doesn't get you there, obviously you take it to the next level. So for our listeners who are hearing themselves or a woman they love being described here, what what things can they do for themselves to start with?
Okay. So first of all, if you have any of the symptoms that we mentioned, I first want to reframe that. And I want you to look at your symptoms as gifts given to you by your body, presents, gifts. Because if we listen to those gifts, if we listen to those signs and signals that our body's giving us, it's basically saying, hey, there's something going on here. There's something that you need to look deeper into because your body was not built to be fat, foggy, fatigued, frustrated, brain foggy, insomnia. It's not built that way. So when you have those symptoms, listen to them. And this is where we move into testing. Let's just start with proper, thorough testing. Everything. TSH, free T3, free T4, reverse T3, and then the two antibodies that we talked about, TPO and TGA antibodies. You need that full panel. If your doctor says no to testing, it is time to get a new doctor. Because if your doctor won't even order what he or she needs to look at to see inside of your body to pair up those symptoms with actual markers so we can say, okay, this makes sense. This is why you're gaining weight, Susie. This is why your hair is falling out. This is why you're dragging yourself through the day relying on Red Bills. This is the why. So we need the testing to overlay on top of really the four most important words that any practitioner can ask you. So again, two rules. Number one, if your doctor says no to testing, it's time to get a new doctor. Number two, if any practitioner that you're working with does not ask you this, I want you to leave. Ready? How do you feel? So that really is the most important thing that any practitioner can ask you, any doctor, any nurse practitioner, any PA, anybody, functional nutritionist, I don't care. They need to ask you how you feel because we have to overlay your symptoms with those labs. And then we get that beautiful picture. Then we can move on to, okay, how do we address these hormones that are a little bit low? Now, I know you're asking the question, Jack, that what can people do like at home to improve their thyroid function? There's iodine, there's selenium, there's magnesium. Make sure you're not deficient in those vital nutrients that the thyroid gland needs as building blocks to actually make enough of your own thyroid hormone. So we can do things like that. Obviously, eating clean, all the lifestyle stuff that you talk about on the show anyways, getting sleep, exercise, eating clean. But let's face it, I was doing all of that and I still got punched in the face with a thyroid problem.
That's what's
So,
freaky.
yeah. So that's just the reality. And the reality is it is okay to use hormones that your body is no longer making. Because I know a lot of people have a stigma against medication. And I get this question like, oh, is there a way that I can fix this naturally? And that's why I even say about the book. I said, it's not a cookbook. It's not a recipe book. It's not a workout book. You're not going to find workout plans in there. And you're not going to, it's not a full book on how to heal your thyroid naturally with this fairy dust that will sprinkle on you. No, it is raw, real, and truthful. And I am honest in there in that most of the time, you're going to need thyroid hormone replacement. When your thyroid craps the bed and it's not making those hormones anymore, and Pac-Man has gotten into it and it's now itty bitty, you're probably going to need hormones. And this is what I explain. I know I'm going off on a tangent, but I think it's important. So bear with me. So this is what I tell patients or anyone that kind of has that little bit of hesitation toward adding in the thyroid hormones that are literally going to give them life. I say, okay, so let's just say you take your kiddo to the doctor and they run and they come in, they go, I'm sorry, your child has type 1 diabetes. Their pancreas is no longer producing this hormone called insulin. So we're going to give your child this insulin pump and that's going to fix things. It's going to make them good. It'll keep them alive, all that. And you go, I don't know if I don't want my kid to take a medication. That's a medication. Can't we do this naturally? And the doc will go, then your child's going to die because insulin is literally required for life. Now, are you going to die without thyroid hormone? Yeah, eventually you will. It'll be slow and painful, and you'll get all the symptoms first, and it'll start affecting your heart, and you're going to have a lot of issues, but it'll be a slow death. But the bottom line is you're not going to have a great life. You're not going to have a high quality of life without that hormone. So we need to take the stigma off of thyroid hormone replacement as being a medication and put it over here in the bioidentical hormone replacement that now we're shining a spotlight on in the world, in especially in women's health, as okay, now we know hormones are great. Hormones give us life. We'll put thyroid hormone in that category too.
Is this not recoverable? Once you're there, you gotta, not reversible, I guess is the right word.
Yes and no. So if we can catch someone in the beginning stages, now I will admit in my clinic, we see people that have been misdiagnosed and frustrated and churned through the medical system and all of that. Sometimes even through functional medicine, where they were working with a functional medicine provider, and because they had functional in the title, they thought, oh, this person's going to know what to do with my thyroid. No, they're not a thyroid expert. They're a gut expert. So you went to the wrong place. So even in our clinic, we're going to see people that they're basically too far along. Whereas if you can catch someone in the very, very beginning stages, like stage 1 of Hashimoto's, they don't really have symptoms. We're starting to see the antibodies. Maybe the TSH is starting to climb a little bit. We can do things like black cumin seed oil. That lowers antibodies and lowers inflammation. We can support with iodine, magnesium, selenium, all the cofactors, the minerals, the building blocks, and do the lifestyle changes, removing gluten to stop that autoimmune attack. Things like that will help and can reverse Hashimoto's in the early stages. It really just depends on how far along you are.
Okay.
Yeah, I think that's definitely well said. And unfortunately, we don't catch people early enough. But I think there is an opportunity there that if you can remove what's triggering that autoimmune response, and the thyroid hasn't been too badly damaged already, there certainly can be an opportunity for that. And just following up on what you said about, I fully agree, right? If your doctor won't run this test, it's not the right doctor to be taking care of you. This testing is not expensive. It's funny how often you hear that from doctors. They're like, oh, we don't order that because it's expensive. When you go to, and there are a number of sites where people can order their own labs, that whole panel you mentioned is going to be maybe $150, $100. I mean, it's very affordable testing. And so that shouldn't be really a barrier. I can't really, as much as we knock insurance, usually this testing will be covered by insurance as long as the doctor just says they have symptoms of thyroid disease. Most insurance is going to cover that anyway. That's a big, big first step for people to take. And I think this has been a great conversation. I think this will hopefully help a lot of people who are suffering out there. Tell them a little bit more about where to find you, the book, all of that good stuff.
Absolutely. So the Thyroid Fix book, so you can go to thyroidfixbook.com, not the on the front, just thyroidfixbook.com. And really, this is touting this as the thyroid Bible, the last thyroid book you will ever need. I have everything in it from head to toe, including how to read your own labs, the optimal lab value ranges. And I even get into the thyroid hormone replacement and how that can be tweaked and what you need to look at it, especially if you are on a thyroid treatment right now and you're just not feeling your best and you're still suffering with symptoms. This is actually going to show you what you need to do with your medication. Now, obviously, that becomes then a conversation with your doctor, which I also have in the book of how to talk to your doctor, how to find a doctor, what to look for. So it really is walking people from being undiagnosed and just having the symptoms all the way through the diagnosis, the testing, the treatment, and then what to do after into biohacking, nutrition, exercise, the whole deal. So it really is the Thyroid Bible. So that's thyroidfixbook.com. And then, of course, you can listen to me on the Thyroid Fixer podcast. That's on all podcast platforms. And you can find me and the Advanced Thyroid and Hormone Clinic at dramie.com. So DRAMIE.com.
And that's a telemedicine clinic, right? You work with people remotely.
Yes, we can prescribe to all 50 states, portions of Canada, Mexico, and Puerto Rico. And we really, we are thyroid and hormone experts. That is what we do. That's our jam. Of course, people will say, what about the adrenals? What about the gut? Yeah, I talk about that in the book, and that comes into play. But when you have thyroid and hormone issues, you want to go to a thyroid and hormone expert. So that is what we do.
I have one last question that occurs to me. If you're a woman and you've made it past this danger stage, you're past menopause, is this less likely to occur? Is there any?
It's usually present already. So my menopausal ladies, you are correct, Jack, in that they're not going through that hormonal fluctuation, the up and down anymore. But the chances of them already having it and not being diagnosed are pretty big. So I would say if you are in menopause, you're listening to this, you're in menopause, you're through it, you're like, oh yeah, that was 10 years ago. No, that's not a problem. And you have any symptoms, any of the symptoms that we talked about today, that's where I really want you to test your thyroid and your hormones. Look at them both. Let's look at them both and see what's going on, but really get that testing done. Test, don't guess, because that's going to give you the answers that point back to the answering of that question. How do you feel? So you have the symptoms. Now we look at the labs and we overlay it and we figure out what's going on with you.
Very good. Thanks. This has been really enlightening. I've enjoyed it. She's Dr. Amie Hornaman. The website is dramie.com, AMIE. The book is The Thyroid Fix. As always, we'll make sure that all of this information appears in the show notes so you can click on it and get there automatically. This has been Stay Off My Operating Table with Dr. Philip Ovadia. Thanks for joining us. We're glad you were here. We look forward to seeing you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.